So thank you for the kind introduction. Thank you also for inviting me today. I'm very happy to be here in person. And yes, as I said, we are going to discuss ex vivo graft engineering in allo-HCT. And indeed, this is an hot topic. Despite this is a very long story on ex vivo graft engineering, start many years ago at the EBMT. We have some very nice presentation with some new products. So this is why this is very relevant to discuss this today during this meeting. So just to remember that now we say, yes, why ex vivo graft engineering? We have the post-transplant cyclophosphamide. We have this very nice study that has been published 2 years ago now in the New England Journal of Medicine that established post-transplant cyclophosphamide as the standard approach to prevent graft versus host disease in patients with mass and mismatch donors, in addition to the well-established use in patients with an haploidentical donors. Nevertheless, as you can see on the slide, we still struggle with some severe acute but also chronic graft versus host disease, and it will be interesting to see if we can do better by some manipulation of the graft. And in fact, what is the aim to manipulate the peripheral blood stem cell graft is to modify the content of the cells, because when you are going to take the PBSC graft, you have the CD34 positive cells that is required for the engraftment of the graft, but you are not going to select all the other immune cells that are contained in the graft. So several strategies of ex vivo graft manipulation have been developed. T-cell depletion or CD34 selected graft. We have also some more selective depletion of alpha-beta T cells on CD19 B cells, selections of naive T cells with the selection of the CD45RA cells that are depleted on the new ORCA T cells product. So I will go through all these different strategies and explain the story today. So we have this nice study that we performed with Monique DeWitt last year on behalf of the CKWP of the EBMT to see if people are currently using this graft engineering strategy within the EBMT centers. In the top line, this is not the number of patients that have been treated, but this is the number of centers that are using it. So you can see that people are using it with 88 centers that reported using one or another strategy of graft engineering. And we ask if people are still using it since 2020 in the PTCI era. Are you still using graft engineering? And yes, indeed, the majority, 63 out of 88 centers, are still using some graft engineering. So this is still a topic today. So the story started with some T-cell negative selection of CD33 positive selection. So we said, so we want to do a stem cell transplantation. What's matter? This is an engraftment, so we keep the CD34 positive cells. We deplete the T cells. We avoid graft versus host disease. And we have this first randomized study that was published a long time ago. It was some patients between 1995 to 2000, but more than 400 patients that were randomized between T-cell depleted bone marrow on cyclosporin A versus no T-cell manipulations, but methotrexate on synurin inhibitors prophylaxis. No differences in disease-free survival and overall survival. Nevertheless, they find a higher risk of relapse after the T-cell depletions and a higher risk of infectious events, in particular of CMV disease. And it was explained as the fact that when you deplete the T-cells, you have less graft versus leukemia effect and more infectious events. Nevertheless, there is still some team that are using it. In particular, it is performed in the Memorial Sloan Kettering in New York. And a few years ago, I performed with Miguel Perales a retrospective study to compare the outcome of patients that received ATG. It was some patients from the EBMT registry versus some patients that received CD34 selected graft at the Memorial. All patients with acute myeloid leukemia in first complete remissions, myeloablative conditioning regimens, match-related donors, and unrelated donors. We don't find any differences in terms of overall survival, in terms of leukemia-free survival, but we find an improved GVHD-free, relapse-free survival in patients that receive the CD34 selected graft. Nevertheless, we have more deaths related to infectious events and a higher non-breast mortality in the CD4 selected groups that highlight that we have still this issue of the infectious event with the CD4 selected graft. This strategy of the memorial was also tested in the BMT CTN clinical trial. It was a 1301. That was a calcineurin inhibitors-free study with 3 groups of randomization. So the groups with the CD34 selected peripheral blood stem cells, the groups with bone marrow plus plasma cyclophosphamide, no calcineurin inhibitors, and the last groups with tacrolimus and methotrexate. As you can see, the CD34 selected was associated with a lower incidence of moderate to severe chronic graft-versus-host disease, a higher incidence of non-relapse mortality that were mainly driven by a higher incidence of infectious events in the CD34 groups, in particular of EBV reactivations, including some patients with EBV PTLD. When we look more closely into the overall outcome of these clinical trials, we find no differences in chronic GVHD-free, relapse-free survival and overall survival. Plasma cyclophosphamide was associated with an improved relapse-free survival, and there was a lower incidence of chronic graft-versus-host disease with the CD34 selected. Doesn't translate into a survival improvement because we decrease the chronic graft-versus-host disease, we improve the GVHD-free relapse-free survival, but we have more infectious events, higher non-breast mortality, and no benefits in the overall survival for the patients. So, why we have this? This is, as I told you, the depletion of the T cells, so we have a delayed immune reconstitution. Here, this is the immune reconstitution after CD34 selected transplantation. This is time in years, and as you can see here, up to 5 years after transplantation, the CD3 level don't go back to normals, in particular for the CD4 positive cells. We have also a delayed immune reconstitution of CD56 cells. This is the NK cells. And when we look at the gamma delta T cells in the upper panels, this is patient that receive CD34 selected graft. In the lower panel, this is no CD33 selected graft. We see also delayed in gamma delta T cells. So delayed in gamma delta T cells, delayed in NK cells immune reconstitutions compared to a patient that receives standard graft that lead to this higher risk of relapse on infectious events. Based on that, other team tried to evaluate a different strategy to have a more refined strategy with only a depletion of the alpha-beta positive T cells and of the CD19 B cells. It will allow to have less graft-versus-host disease with less alpha-beta T cells, to have less EBV reactivation on PTLD with less B cells, and to keep the graft versus tumor effect and to have a better control of infections because we'll keep the gamma delta T cells on the NK cells in the graft. So here, this is how it's worked. So this is a graft composition. As you can see in the left panel, this is before the depletion. So we have high level of the cells. And after the depletion, we see that this is really a selective depletion with a decreased level of alpha-beta T cells, decreased levels of B cells, but we keep some high levels of gamma delta on NK cells. So it's feasible in terms of graft manipulations. We have several landmark studies that start in 2014 that establish that it's work both in adults and children in leukemia, but also in other non-malignant disease and any hematological malignancy, and it works with related, unrelated donors and haploidentical donors. will go through in detail through a few studies, in particular this one that were published recently from the TRECH groups. That is a retrospective single-center analysis in patients with match-related or unrelated donors or mismatched unrelated donors with 3 groups. In the first group, this is some patients that receive some with match-related donors and only cyclosporine A and mycophenolate prophylaxis, so T-repeated graft, so standard graft. Another group, this is for unrelated donors when they add ATG because this is unrelated donors. On the last group, this is patient that receive some manipulated graft with the depletions of the alpha beta T cells and of the B cells. As you can see on the slide, so I am as you can see in the slide, in the patient that receives the manipulated graft, we have a decreased incidence of grade 3 to 4 acute graft-versus-host disease. We have also a very low incidence of extensive severe chronic graft-versus-host disease, no differences in relapse. And when we look at the GVHD-free relapse-free survival, it was higher also, it was not statistically significant in a patient that receives T-cell depleted graft, and no differences in overall survival. So it seems to be interesting. It seems to be an effective strategy when we compare to other strategy to prevent graft-versus-host disease, very low incidence, but no benefit in overall survival compared to the other strategy. Regarding the infectious events, we still have a higher incidence of CMV reactivations in those patients. So even if we keep the gamma delta on the NK cells, we have still more CMV reactivation. I must highlight that this is some data before the use of letermovir. Now it's really no longer an issue, the CMV. And what is very important is that the EBV that was very high with the CD34 selected graft, here the EBV viremia are not increased compared to the other patients. We then, it was also evaluated in a multi-center phase 1-2 study. So here we have some very good outcome, very low rate of severe acute graft-versus-host disease, 21% of moderate to severe chronic graft-versus-host disease. We have a high disease-free survival, GRFS, overall survival, low non-relapse mortality in those patients. What is more interesting for this study this is to look at the immune reconstitution in those patients, and they find that we have a quick reconstitution of the NK cells. So when you keep the NK in the graft during the manipulation, we have a better recovery of the NK cells after transplantations. And they were also able to show that we have a higher number of gamma delta T cells, and in particular, when they look at the repertoire, it undergoes a very good clonal evolution in the early post-transplantation period, so they are able to keep the gamma delta T cells that will contribute to the graft versus tumor effect. They also compare, and this is a study that we performed on behalf of the CTIWP and that presented at the EBMT this year, where we compare 3 strategies. So the alpha beta TCR CD19 depletion, I just show you, PTCy, and also another strategy of T cell depletion that is compact in the bag. So you put anti-CD52 compact in the graft bag, and it will do an ex vivo T-cell depletions. And it is a multi-center retrospective analysis where we were able to show that we have less extensive chronic graft-versus-host disease in patients that have the T-cell depleted graft compared to post-transplant cyclophosphamide. And we were also able to show that we have more relapse with the compact in the bag versus PTCy, but no increase of relapse into the alpha-beta TCR CD19 depleted groups. When we look at the GVHD-free relapse-free survival, there was no differences between PTCy and the alpha-beta TCR CD19 depleted groups, and also no differences in overall survival. We only see that it seems to be the compact in the graft that have some worse outcome, so we have to be cautious because this is some retrospective analysis. This is some few centers that contributed for the alpha-beta TCR CD19 depletions groups, but it's still interesting to see that compared to the PTCy, it's lead to similar outcome as the now well-established PTCy strategy in those patients. Another strategy now is to have some selective naive T cells depletion. So why this is interesting to deplete selectively those patients? Because these naive T cells has antigen inexperience. They have a very big T cell repertoire and are likely to include some T cells specific for minor histocompatibility antigens that may contribute to graft-versus-host disease. On the opposite, if you keep the memory T cells, this is some antigen experience pathogen specific, and that may contribute to the graft versus tumor effect, but with fewer minor histocompatibility antigen specific T cells, so that will contribute way less to graft versus host disease. So we have also some marine study that showed that the graft versus host disease severity was associated more with naive T cells than central memory or effector memory T cells, so it seems highly relevant to selectively deplete those naive T cells. And it was then evaluated in several studies, prospective and retrospective, and in particular, we have this paper in GCO 3 years ago by Marie Bickley that combined several prospective studies that include both adult and children, both maltreated and unrated donors, mainly myeloablative conditioning regimens, and at the end we have 138 patients in this study. So, as you can see here, we still have some grade 2 acute graft-versus-host disease, but very low incidence of severe grade 3 to 4 acute graft-versus-host disease, very low incidence of any grade 2 or 3 chronic graft-versus-host disease. So, very low incidence of severe graft-versus-host disease, both acute and chronic, but they perform a multivariable analysis, and they find that the onset of graft-versus-host disease in those patients was associated with some relapse. So patients with without graft-versus-host disease have more relapse. So it seems that we have this protective effect of the graft-versus-host disease. So when you prevent relapse, when you prevent graft-versus-host disease with this strategy, you still increase relapse. So it was an issue. And when we look at the relapse incidence, it was 23% at 3 years. So still high, but very low non-relapse mortality. And the overall survival was good. So based on that, despite possible increased relapse incidence, several phase 2 randomized clinical studies are ongoing, both in adult and children. So we'll see in the next few years if they validate this finding prospectively and in a randomized way. The last ex vivo graft engineering manipulation I want to discuss today, this is the ASTCT, that is called precision engineered cell immunotherapy. And in fact, here this is a more careful manipulation of the graft because we are going to give to the patient a defined cell population of CD34 positive stem cells, regulatory T cells, and conventional T cells. And in fact, the graft are taken in the patient. This is manipulated. We will separate the CD3 positive T cells, the regulatory T cells, and the conventional T cells. On the day 0 of the transplant patient will receive the CD33 positive cells. He will receive the regulatory T cells, and 2 days later, he will receive the conventional T cells. So this is only with fresh cells. There is no cryopreservations, so performed in the local facility. And as you can see, it will allow to infuse to the patient a very precise dose and ratio of regulatory T cells to conventional T cells. And when we compare to a classical CD34 selected graft, patient will receive a higher number of T cells, conventional T cells, but we know that we'll also infuse a higher number of regulatory cells that will counterbalance and prevent the onset of graft-versus-host disease. So it's very exciting to see how we can manipulate the graft and deliver some patients some very well-defined dose of the different cell subset. So what it gives in clinical practice? So we have this first phase 2 study that were published in Blood very recently, this year, that treated 44 patients, myeloablative conditioning regimen. So they received some tacrolimus and mycophenolate mofetil for patients with an unrated donors. and they were able to compare these patients treated in the phase 2 study to 121 patients that were treated outside of the study and that were it was a retrospective comparison. And in fact, with the ASTCT, we have a significantly lower incidence of acute and chronic graft-versus-host disease and a significantly better GVHD-free survival. So very promising. At the EBMT this year, several studies have confirmed this finding. First of all, we have this phase 1b safety study with 150 patients that confirmed that ASTCT show low graft-versus-host disease incidence, low infectious rate. As you can see, we have only 28% of the patients that have grade 1 to 3 infections, but when we look at the grade 4 and 5, it's only 6% of the patients, and that exhibit a high survival. So they were able to select a subgroup of patients that were treated in this phase 1b study and to compare them with a well-matched cohort of patients that receive classical post-treatment cyclophosphamide for the GVHD prophylaxis, and they find in this retrospective analysis, but per match analysis, that patients that receive the ASTCT graft have an improved overall survival, very low non-relapse mortality, and improved relapse-free survivals. They also compare some patients from the same phase 1b study, so now they match them, so it's another subgroup with some patients that received some CD34 selected transplantation. It was some patients from the Memorial Sloan Kettering, again for the CD34 selected cohort, also per match. This time they did not provide any data regarding the overall outcome in terms of overall survival or GVHD-free survival. They want to compare the infectious events on the immune reconstitution, and as you can see here, we have some increased T cell count on the better donor chimerism in the ASTCT patients, and this translates into a very good infectious control, since we have a very low incidence of EBV and CMV reactivation in those patients, with a clear correlation between the T cell reconstitution and the low incidence of EBV and CMV reactivations. Finally, the main study that was presented, it was a phase 3 study. So it is a randomized study. So it was one group, it was the ASTCT plus tacrolimus, myeloablative conditioning regimen. So they received day 0 CD34 selected cells plus regulatory T cells, day plus the conventional T cells. And for the prophylaxis, they received only tacrolimus, no methotrexate, no post-transplant cyclophosphamide. In the control groups, it was a non-manipulated graft with tacrolimus and methotrexate for the prophylaxis of graft-versus-host disease. So here, this is the overall outcome. So we have significantly better moderate to severe chronic graft-versus-host disease. That was the primary endpoint of the study, and it was highly statistically significant. Regarding the survival outcomes, so non-relapse mortality, 3% in the ASTCT arm versus 13% into the standard arm. No differences in the relapse-free survival, and good engraftment in both arms, and we have a decreased number of adverse events in the ASTCT arm. So the conclusion of the study was that the ASTCT was associated with an improved survival-free of moderate to severe chronic graft-versus-host disease. It was associated with a decreased chronic graft-versus-host disease, improved GRFS, on a trend to an improved overall survivals, and very few severe adverse events. We must highlight, nevertheless, that in the control arm, it's not the standard of care for us. There is no post-transplant cyclophosphamide, there is no ATG, so we will expect to have some comparison with really the new standard of care to clearly establish the superiority of this strategy. So to conclude, we know that ex vivo graft engineering is feasible, is still feasible, and is still done in both children and adults. Ex vivo graft engineering is associated with very low incidence of severe, acute, and chronic graft-versus-host disease. We have some different approaches. We have some improvement in the approaches with more selected approaches that lead us at the end to these new RCT approaches. We have some very careful design of ex vivo grafts seems to decrease the risk of relapse on infections. If you keep the good cells, you avoid the bad cells that lead to graft-versus-host disease. That improves the non-relapse mortality compared to the first study with just T-cell depletions. We have the importance of the immune reconstitution pattern, and it will depend on the strategy used for the manipulation of the graft. Multi-centers, prospective, randomized study are very important to validate those findings. The question of the cost is still important because, of course, it's more expensive to an ex vivo manipulated graft compared, for example, to PTCy that is very cheap. But if we have a decreased incidence of chronic graft-versus-host disease at the end, it will be less expensive, or at least no more expensive at the end, maybe. I don't have time to discuss for time's sake the part of the DLI because it can be also part of the ex vivo graft engineering that we can give to the patient some manipulate DLI after to enhance the graft-versus leukemia effect. And overall, this strategy can clearly improve the quality of life of the patient. So here I will end, so I will be happy to take questions, but I think this is at the end of the discussion. Thank you.